Hey people, how you doing? Welcome to the Sports Therapy Association podcast, being recorded as always live on the Sports Therapy Association YouTube channel. We are going out on a Wednesday tonight, but normally it's on a Tuesday at 8 o'clock. And if you're listening to the podcast and you like the idea of joining us live, then that's all you got to do. We've done it for 150 weeks in a row, so we're not going anywhere. Just head along to the Sports Therapy Association YouTube channel at 8 o'clock, normally on a Tuesday. And it's a great idea to join us live if you can, because you get to network and hang out with other soft tissue therapists who are filling our lounge up as we speak. So hello there to Penny from Soma Sports Massage Therapy. Good to see you. Glenn Murphy is here as well. Hi, Glenn. Nikki Mansfield is in here. All the regulars are here. Nikki says, hello, my fine fellow people squeezers. On this fine day, Nikki's still, on cloud nine, having opened up her new premises and started hosting courses. So good to see you, Nikki. Good to see that medication still working. Penny's here as well. And yeah, fantastic. So people are coming in. So you've always got that option. If you like what we're talking about and you want to join us live and ask questions to the guests directly. So this month, we have been focusing on the abdomen and the groin. Just a little recap in case you have jumped in at episode 150 and you've missed out the other ones. In part one at the beginning of the month, my guest was Dr. Sarah Rollins, who gave us a fantastic breakdown of the anatomy of the anterior abdominal wall, as well as a look at the cause of hernias, diastasis recti, and a lot more. And that is on YouTube and also on all popular podcast apps if you'd like to catch up with part one of this month's focus. Part two last week, I spoke with Dr. Dora Papadopoulou, who looked at the anatomy of the groin, looked at different diagnoses, and also a selection of surgical procedures that can be used when conservative measures are not getting results. And tonight, in part three, waiting patiently in the lobby, we will be shortly chatting with special guest Benoy Mathew of Function to Fitness about treatment for groin injuries. Really looking forward to this one. And there was a lot of theory last week. And this week is going to be lots of practical stuff which soft tissue therapists can take away with you and hopefully start using in the clinic tomorrow morning. Next week, and I'll announce it again at the end of the podcast, to end this focus on abdomen and groin, my special guest will be Jenny Burrell of Burrell Education, who will be taking an in-depth look at diastasis recti, also known as abdominal separation. So that will be Jenny Burrell next week. There we go. It's been a great month so far. Tonight's not going to be any exception. As always, if you've got questions, and feel free to put them into the chat and I will bring them up on the screen. But as I say, tonight we're going to be chatting to special guest Benoy Mathew. A lot of you probably are familiar with Benoy because of his extremely popular Function to Fitness lower limb courses. He's a MSK Extended Scope Practitioner in the NHS and also private practice, with a special interest in treating complex lower limb pathologies, including chronic hip and groin patients. Definitely recommend that you follow Benoy, and we'll give out some links at the end of the show on social media. A lot of fantastic information out there. But as far as the next hour goes, you haven't got to go there. You can stay with us and listen as I bring up my guest for tonight's episode, Benoy Mathew. Hey Benoy, how you doing?
Hi, Matt. Thanks for having me. And I think it seems to be working all well with all the IT stuff, which is always a good place to start, isn't it?
This is good, isn't it? Everything is working. Nothing's going to stress us out, at least here for an hour. And we're double pleased because you were originally booked in to come in January, weren't you?
Yeah.
Bugs got hold of you and family, and so you are well now, are you?
Yeah, good, all good, and it's still, it's a lovely day as well. It's sort of. Still a bit of sunshine. It just had a little bit of a short run, so it's good to get that sort of endorphins, feel good factors. We all need that, we all need
that. No doubt. That's why I had to rush off a glass of water. I went for a run today and just a bit more dehydrating, and
I'm just playing around with show rotation, which is I'm a bit of a show geek. We can have a chat later on that, trying off different types of I've just recently moved from Saucony and I'm just going more into the Hoka range, so I'm trying out a few of
really?
So so it's quite a few of things.
Is that an age thing? Is that
yeah
because hurting a bit?
But more
generation.
I just saw more excuses to buy more shoes. My partner is complaining that we've got enough shoes, but I feel like I'd have more.
Yeah, that's great. Yeah, we can chat about that definitely later on. Right, fantastic. So last week, Dora was very excited. She thought it was a wonderful flow because last week she was talking a lot about the anatomy. She was talking a lot about the diagnosis and talking about a lot of the work that she's doing to try and simplify and improve diagnosis on a European international level, because there's a lot of misconception out there and a lot of error maybe that is caused by people diagnosing differently and using different terminology. But she was very excited to leave treatment to you. She's like, Benoy will be able to look after that. Benoy will be excellent. So she really bigged you up, basically.
Yeah, thanks.
I mean, tell us a little bit for people who haven't heard of you, which I'm hoping some of our listeners haven't.
Yeah.
What got you into particularly interested in working with lower limb pathologies? And
yeah, I think when I first started within there was in Hammersmith. Like when I started with my extended scope, there was we're seeing quite a few. I was treating quite a few runners at this time. As you know, one of my areas of interest is running, and we were seeing one of the things which made me really interested was I've seen like couple of female runners who had this sort of niggling groin pain, and they're treated with appropriate rehab and soft tissue work, but they're not getting better. And when I scanned them, then they came up with like a bone stress injuries, and it was quite shocking for me because externally there was nothing obvious. It came like a bit of adductor niggle, and so the one thing which sort of started me was the mismatch between how it presents and what actual problem is. So it can be quite subtle in many patients, and then they get really worse, and then you scan them, you have a fracture or a bone stress injury. And other area was the distinct difference between men and women. So so I was treating a lot of men with adductor pain, but in women they have very unique. It's one of the area of the body where you have clear difference between men and women with pathologies. So and I found that was quite. Whereas a simple like the knee or other joints, they're fairly straightforward. So I find that sort of challenge, and when I showed interest, my colleagues start dumping me all those cases, and I said I want to get in, and that is the best way to learn. You just put your hands out. So this was more towards the 2010, 2012, and then I went into conferences, did stuff, and I got really involved. One of my friend had a hip impingement, so I rehabbed him. So there's hardly anything at that stage, So it came as a curiosity for me, and then this still I'm learning on that. So it's definitely an area where we need more therapists to get involved, because we have excellent therapists for example, shoulders and backs and knees, but the hip and groin, generally a lot of people are put off with it, which doesn't have to be the case. So we can really make a big difference, and this has a big effect on patients. Like when you have like a chronic groin pathology, like you can't sit, you can't get out of the car, even like intimate relationship with your partners, playing with your kids, it's really, and you might be just like 27, 28. So it has a big physical and psychological impact on people, and it's such an awkward area, isn't it? Like it's pretty much next to your genital region, and it can be very comfortable. So I think making a difference in these people can be a real life changing experience for many of those. So that's one of the regions, because the constant achiness around the groin really drives people nuts. A lot of my patients tell me that sort of makes them really having that issues as well. So that sort of personal impact made me think like I need to really get in there, and that's what got me into education and try to simplify the area as well, because a lot of things which we see in complex elite sports doesn't happen in, for example, a typical case is sports hernia, but you don't really see that in a normal clinic, really. So sometimes people get excited with all these complex things, but they are not what you see. So sometimes we have to stay grounded on what is more common and what's more applicable in our day-to-day clinical practice.
That's quite interesting. Actually, we were talking a bit off air about that. Sports hernia is something where finally sports therapists and sports massage therapists and sports rehab therapists go, finally something which has got our name in their name, and they're going to come and see us because they think we only deal with sports people. Even that's a good example where it's a misnomer, isn't it, where the name is given out where it shouldn't be used. Can you go a little bit into that?
So I think one of the things to look into when somebody comes with a groin pain is to make sure that they don't have hernia. But the hernia is, from my experience, GP are quite hot on it, because there's quite a lot of drill on the medical school to pick up this. So if you have a true bulge, like when they cough, they have a bulge and they feel like a swelling, majority of the time the GP will send for a simple, like ultrasound, and they'll pick up. There are two types of common hernias. One is called a femoral hernia and inguinal hernia, and the GPs will generally, immediately take action, refer to the, general surgeon. So those patients, you don't really see them because they've been picked up. But having said that, I picked a few, especially post-COVID, where I'll give you two examples. One was a guy who was working in a very sedentary, normal sort of sitting job, and then he lost his job, went to work in Amazon, a lot of lifting, and then a lot of straining, and then he felt, a bit of a groin ache, and he came to me, and then typical signs like when he coughs and sneezes, a bit of a bulge, and I said, this is, I think you have to go to your GP, and did an ultrasound, picked it up. So, and the other one is where people have sudden spike and heavy weight training in the gym. So one was a guy who was really ramping up a deadlift, lot of deadlift stuff, and then he felt a bit of a bulge, and they don't have a traumatic onset. It doesn't come like in one day. It's more like an ache, and then when they cough and sneeze. So typical would be when they cough and sneeze, they might feel a bit of a bulge sensation. They will not have any pain at resting and at night. So there's no pain when they don't know nothing. It's only when they strain, when they do ab work and things like that. So if a patient comes in with those symptoms, so quite straightforward diagnosis, refer to your general practitioner, and they usually take care of well. Other thing to remember when you deal with that area is because it's got close proximity to the genital regions, so it's always a good idea to screen. So if a male patient comes to my clinic with groin pain, there are a few things I'll ask. So I'll ask, have you noticed any swelling, around the testicle region, any pain around your perineal or penile region, any change in your bladder and bowel function, and any pain during sexual activities, and men, as we know, I can vouch for that. They're very poor historians, and they don't really tell you unless you dig them. And you might be the first person to pick this up, and then we don't have to scare them. We just have to escalate and say, maybe you need to see your so this was like one triathlete I treated who came with the groin adductor pain, and I asked him the same question, and he said, yes, there's a bit of swelling around my testicular region. I said, I think you should seek your GP straight away. And unfortunately, he had like a bit of quite testicular cancer, but it was in early stages, and it was so you could be the first person to pick this up. Because, and I asked him, you had it for 7 months, why you didn't do anything about it? And he said, I thought it'll just go away. But sometimes people come with weird answers. So around so this sort of things, for me, those are really important to pick up, those sort of red flags. So any growth around testicle regions, any issues with their urination or numbness around the genital regions, So that's for the men. So the women, it's also equally important to ask about pain during sex, any bloating sensation, because women's pelvis, because they are more like, they might have conditions like endometriosis, polycystic ovary disease, and things like that. We don't have to make any diagnosis there. We're just saying, like, if they have pain during sex and the pain changes during periods, then seek help with the physio who does women's health physio or the GP. So for me, that is really priority on day one, is making sure that I'm not missing those non-MSK conditions, which can be managed quite well if they're with the right person, because that's not really my area of expertise. So one of the things I've picked up in the last 3-4 years working in hip and groin, I work very closely with a lot of physios and other therapists who work with women's health and men's health, because many of those patients need both. So I can manage the hip and the adductors region, but somebody else will work on the pelvic floor and things like that. So you need to have that relationship with other professionals, because you do have that sort of close relationship between the pelvis and the hip. You can't separate it, the pelvic floor and the hip muscles as well. So we're coming.
That's really good to hear. Sorry to interrupt. That's really good to hear, because we've heard that message so many times. And when it comes to soft tissue therapists, particularly sports massage therapists, sports therapists, they may well be, I'm talking to you guys listening to the podcast now, you may well be the first person who this person comes to, because they are probably willing it in their mind. I need a massage or something. I just want to get away.
Oh, I just got a tight adductors,
Yeah, exactly.
Yeah.
So if again, if you're asking the right questions, if you're concentrating on the subjective, putting in those questions without any embarrassment, just getting used to it, because all of the guests we've had have said, once you ask them 2 or 3 times, any problems during sex, any problems going to the toilet, you won't be embarrassed anymore. They're not going to be embarrassed. And as a business model is huge. I mean, if you get 1 or 2 cases, I mean, it sounds horrible, doesn't it? But you send someone to the GP and it gets diagnosed as cancer, you don't wish it on anyone. But if word goes around that you were the person, you're going to be in the Argus, that's for sure. There'll be a picture with you on the front. It's always going to happen. And so, one, you're going to feel better about helping somebody, potentially life-threatening thing. And 2, your business model is just huge. Because you will get known as the therapist who's doing, asking the right questions. So,
and the thing is, the point there to say is, because I too had that hesitation. So there are a couple of ways you can work around. One is to explain that, is to understand that it's linked up. So I say, like, I'm going to ask you a few personal questions, but this is linked up with your hip and groin. So they understand there's a link, what's the relationship. And the second thing is to say, like, that those sort of symptoms is something coexist and might not mean anything sinister. So it doesn't mean like it's always cancer or anything. It could be a simple hernia, but the main idea is we are, and they really appreciate that you're looking at a holistic picture, not just purely muscles and tendons alone. So they feel like, oh, nobody has asked me. One of the first questions people always commented is, you're the first person asking this, and then immediately they think, okay, he or she needs to know what they're talking about, because as MSK therapists, we see the world in just MSK. The body is beyond. There's so many systems there, so it's easy to forget that there is so many other other systems and organs and nerves involved in that. So we're just dealing with a small part of the anatomy there. So there are other things which could be linked up with those. So it just makes us grounded of the bigger picture.
Definitely. It's funny because holistic, like 10, 15 years ago, holistic had kind of hippie connotations of, oh, you're gonna light some joss sticks and you kind of, check someone's chakra. But now we're using the term holistic in a sense of, you're not just focusing on that adductor, you're actually looking at the whole person, doing a subjective properly, looking at the other body system. So it's good. Therapists, you can now use the word holistic again without fear of rebuttal and people taking the mic, because it's what we should be doing.
And I think with the thing which is quite topical, which is relevant here, is there's a lot of interest and awareness about, like, for example, in menopausal treatment, with the hormonal HRT. So I have this is sort of a couple of patients who came with simple GTPS patients, with great trochanteric pain syndrome. They're quite severe, and then I saw them a couple of weeks ago, and they started HRT, and the symptoms were so much better with that hormonal, with the estrogen and testosterone. Just made me think, how much is MSK pain in that group hormonal, and how much is it purely a load issue? So clearly we can see those sort of factors are important, so getting the right medical support with the hormones, weight management, recovery, sleep, and then our job becomes much easier, isn't it?
Definitely. Jenny Bowl, our guest next week, she was on the show before, and she spoke at length about understanding how tendinopathies are different in the population of women who are perimenopause and menopause. It's like you have to reconsider what could be going on if you ask the right questions. Very interesting. So, Mr. Treatment Man, how are we going to start talking about treatment for some of these conditions?
Yeah, so the thing is, we need to put them into boxes here before we, so rather than just saying groin. So the most common condition which you're going to see in most settings with groin pain will be coming from the hip joint. So if somebody comes in and says, oh, I got this sort of tight hip for like 2 years, it could be the early sign. So one of the things which I see a lot of misconceptions is, oh, for example, I had like a 38-year-old runner, high level. He's having this constant stiffness, and he tried a lot of soft tissue work. He did have improvement, but it's just short term. And every time he did a lot of incline running, a lot of speed work, he used to limp for 2-3 days. Then he came to my clinic, and I have some key questions I ask when I suspect hip osteoarthritis. So things like, do you have difficulty putting shoes and socks in the morning? That's a classical one, So if you're really struggling, a 38-year-old man or woman shouldn't really struggle with that, isn't it? Whether putting shoes and socks in the morning. And then when you sit for long periods, when you get up, do you limp? And if you do a lot of speed sessions, how is it the next day? So those sort of subtle signs. And then I said to him that we should send you for an X-ray, and he was surprised, and he said, and the typical answer was, I'm only 38, and my hip pain can't be because of osteoarthritis. And so that's a bit of a misnomer, that you only get arthritis when you are like in 50s and 60s and 70s. We know that there is some predisposition, especially if you have some childhood issues, and if you're a male, and if you've done a lot of rotational sports when you're young, you're more likely to happen earlier. So common things happen more commonly. So chronic stiffness for a long period, and especially getting slowly worse, the first thing I'm going to think is simple osteoarthritis. And you don't have to rush for an MRI. Most GPs will be ready to get an X-ray. And now, doesn't mean that if you have an arthritis that you're going to need a replacement in the next week. It just shows that no amount of soft tissue will replace that, because when you're losing that mobility around the hip, the soft tissue sort of try to overcompensate, and they sort of take over the role. So they'll be needing a bit of that hip work as well as the soft tissue work. So those something I see missed is, especially in the 30s and 40s, they sort of forget that they can get hip osteoarthritis. So it's more common than you think, because the typical presentation is after 50 or 60. So that's something to think of, is that chronic tightness. I'm going to think of osteoarthritis first. If it's more,
definitely,
that's
really good. That's a really good message for our listeners, because I'm sure a lot of people will not even consider that. If the patient is like 35, 38 years old. I was interested in something you said there, looking at the case histories. Obviously, you look for kind of maybe a genetic trait or something in their childhood. What was you said about if they're a child and there's evidence that they've been doing lots of rotational activities as a child?
So male elite sport. If you look at the data, like male top level professional football, hockey, those sort of things, it seems to be they end up with the. So if you look at, like, for example, ex-managers football, or ex players, and you follow them, many of them will have a replacement hip by their 40s. Like typical, like Andy Murray, he had a hip resurfacing surgery. So there seem to be some link of high level of rotational sports in your teenage and 20s, which sort of predisposes certain people to develop. It's a risk factor. It doesn't mean like if you've done. We're talking about people in very high level elite. We're not talking about somebody like like an average bloke. So if somebody has done a very high level sports, they are statistically they are at a higher risk of developing osteoarthritis. Maybe they had a lot of injuries, maybe sort of factor. So it's quite pinpoint. So but that generally is a factor. But the main risk factor of getting early osteoarthritis is issues when they're young, if you have childhood hip disease like dysplasia and perthes, because sometimes it happens so young at 4, like normally perthes happens between 4 and 8, and people forget that, and they come to you in their 30s, and they have that. So one key question to ask would be something which I usually ask with all my chronic hip and groin is, if they have a family history of early replacement, and early replacement is below 60. So if somebody says, somebody like you comes and say, my mother had a hip replacement at 48, makes me think, why is that? Why did your mother have hip replacement at 48? That's too early. Then sadly, those sitting past genetically. So again, asking them, anyone close in your family, like your parents or sibling, had a hip replacement very young age, then statistically we know that could be a risk as well. So the family history does matter. We're not talking about everyone in the family, parents and siblings, so father and mother and your brothers. So those sort of things are really important. And they say, it's sort of interesting, my sister had replacement like 5 years ago, my mom had it, then pretty much that is also highly likely here. So those sort of things are going. So once it's sort of hip thing, or the most common thing would be is if somebody comes with they're playing rotational sports, anything which involves change of direction, for example, like football, tennis, hockey, rugby. By far the most common muscle you're going to see is the adductors. So generally you don't see that in runners. So a bit of a top tip here is, a female runner comes with adductor pain, when you're talking about a medial thigh pain, makes me highly worried about a stress fracture. So generally female runners don't get that inner thigh pain straight line sports, I've seen a lot of this being missed, and they end up being a stress fracture. So a female runner with adductor pain is a stress fracture unless proven otherwise. So
Very interesting.
yeah. So whereas a male footballer or a male tennis player or a female tennis comes in, that's different. So the sex and the sport are equally important. If you're doing rotational sports, you come with a inner thigh pain, then it's more likely adductor. If you're just doing straight line sport, why are you getting inner thigh? And then you can do a simple like simple hop test, and see whether that causes the pain. If the hop test is positive, then you might refer to somebody else to look into investigations, because that is something you don't want to miss, because a lot of patients will say, oh, got tight rec fem, things like that. And the periods you see is usually the spike before a London marathon or before an event. The typical history. They've got an event coming up, they have the spike in, and then they get a bit of niggles and they stop running and they come hobbling around. Oh, I've got a tight adductors or a hip flexors, and they can't even walk, and that there's something else bony. So anything bony might present as a soft tissue. Again, you need to look at the history. Are they had a spike in running volume? Things like that. You're not going to jump into a conclusion. And again, you say is something we want to miss. So you definitely don't want to miss hip osteoarthritis and stress fractures, especially if you're treating a lot of soft tissue work with runners. And we know from the history, the biggest risk for stress fracture is two things: previous stress fractures and being female. So unfortunately, female have a higher because of so many other factors, metabolic or other factors. But generally, if they had a stress fracture before, even if it was 10 years or 20 years ago, you need to keep a high suspicion of that. All the men can get it, but statistically, women are more likely to develop this, especially if they do long events. And so somebody, for example, has done only 5K and they're doing the first half marathon. They've not done a lot of 10Ks, big jump from that, and they're getting groin pain. That's something you don't want to miss on that. So that's about anything on that you want to?
I was just thinking, and that takes us back round again to asking the right questions, because if it's a female athlete with adductor pain, and like you say, it's a distance runner, then you need to ask about menstruation and diet, all those sort of things, to see if there's
or a change in, suddenly have they become vegan recently, maybe they're not getting, because there's a lot of diets, keto, vegan, are they getting enough calories? And the period is generally a strong indicator. So if they're not getting regular periods, and also maybe they're not consuming enough calories, regardless of the diet, if they're not consuming enough calories, and then they start, and also the first thing which drops in is the drop in performance. So they see that their timings is dropping, they don't enjoy anymore, and then you need to have a very low threshold for imaging, and then refer on for those sort of things as well. So definitely those are the ones not to miss from a hip point of view.
These are great. I just want to, because you're coming out with so many great bits of information, I want to check, and this isn't just me kind of selling your courses, but is this the sort of thing that you find when you do your courses? Therapists come to you and they're not aware of these little things. They haven't learned these tricks. Yeah,
I think this is because it's sort of there's a few misnomers. Is people think the early stage, the bone stress injury, that they get night pain, they can't walk. That's too late, really. Because we know it's a stress fracture is a continuum. Bone stress injury, the last stage is the fracture. In the early stages, they can still walk, do a little bit of running, but they can't really continue at that level, and they sort of limp the next day. So it's a bit too late to pick them once they have a fracture. So ideally, like therapists like us, we should pick it up earlier before they get it, because the return to running is much quicker. Let's imagine that you got a full-blown fracture of the femur. Sometimes it can be 9 months to a year before you get to that level. Whereas you pick them much early, the return to running could be as quick as 2 months or 3 months. So it's a big difference in picking up on that. So, and again, sometimes the patients also want to believe that it's a soft tissue, that it's sort of, so what I tend to use with these patients now is, I don't hardly ever use the word fracture. I just use the word bone stress injury, just like you got tendon injury, muscle injury. It's a bone injury, bone stress injury. So I said to the patient, see, runners are high risk of bone stress injuries. And we know that if you don't pick this up early, it could lead to, a lot of complications. And they don't get picked up on an X-ray initially. That's a problem. X-rays don't pick this up in the initial stages, so it'll come back as normal. And they definitely need an MRI. And that's another problem I see. So they go the local GP, they get an X-ray, and the X-ray comes back as normal, and they think there's nothing wrong, and then they keep running on it, and then you get a full fracture. So that's why access to somebody like a sports doctors or an orthopedic surgeon locally who can get an MRI is crucial, because otherwise you're just falsely reassuring them that everything is fine, but actually the bug is winning. So getting X-ray is pretty. The sensitivity is less than 50%, which means you might well as toss a coin and rather than send for an X-ray. So your chance of missing it's very high, especially in the early stages. And what will the runner do when they have the X-ray and the X-ray is normal? They're not going to stop running, are they? Because they've been told no fracture, and they keep running on it, and then the worst consequences happen. So again, telling them, like, early stages of that sort of injury is not picked up on an X-ray, and especially if you got somebody at a high level, we don't want to miss that. So it's getting an MRI, and again saying them, there are two things I sort of use with the runners. One is explaining that if you pick up earlier, then the return to running will be much quicker. So we might only need 2-3 weeks or few weeks rather than at a late stage. And the second thing is, your complications rate is much lower, with those things. So I think sometimes you have to give like a good or good news and a bad news, something you put without fear. We don't want to create fear there, but at the same time, there's that fine line without making them understand the seriousness of it as well.
Very good point.
Yeah, so on that. So
we're just going to make sure Nikki just raised the point in case anyone else is not hearing it correctly. Yes, it is the adductor muscle. It does sound a bit like erector sometimes. Thinking, it is actually the adductor.
Maybe we can, adductor. Some call it adductors. Adductor. So it comes from the inner thigh, and generally that is the most common injured muscle in when you do rotational sports. So if you look at like professional sports, I would say, where I read somewhere, if you look statistically, the most common muscle injury was hamstring. Number 2, I think, was adductors, and the third was calf, I think. So those 3 muscles are the most commonly injured muscles which you see when you do any change of direction and change of sports as well. So you're going to see, and many of those patients will need good soft tissue work and keep the flexibility going. So when we talk about adductors, one of the things is, so this is quite a good relevant point here, is the location of the pathology and the pain. So some people it's more within the muscle belly itself. Some people it's more towards the tendon. So if it's more towards the tendon, anything towards the bone, those patients don't like aggressive stretching, because we know that tendons, they're not a big fan of a lot of stretching. So if you're doing a lot of stretches in that group, you might potentially flare them up. Whereas if it's more towards the muscle belly, you can be a little bit more aggressive. So the location of pain also guides us how much we can be strong. If it's just purely a muscle thing, then you can be a bit more aggressive, do a little bit more stronger, and just do a bit more passive active assisted stretches. But if it's more towards the bone, then that gets a bit trickier. So because you can't really stretch it out a tendon and get it better. So because they'll need the strengthening protocol with various forms of exercise we do, and then you might do the soft tissue. So the location of pain is equally important. Is it more the muscle or is it more the tendon?
Another great point. Fantastic. So so maybe let's, treatment. Let's go with adductor strain.
So let's go with that. So when you go into that, so we can put that into sort of different stages. So I think, let's say somebody comes in, they had like an adductor pain for like 8 months. It started after they started playing fireside, or you do see that in runners. In one type of runners is trail running, because in trail running, there's a change of direction a little bit,
True.
And also you see a lot of, men and women, as they get middle-aged sort of master runner, they lose hip mobility. So that's a well-known fact. As we get older, men lose hip mobility more than women for some reason. So that's a true fact, is the hip extension is lost. And when you lose that, you're less efficient and there's more strain around the pubic region. So that's one theory why you end up, as you get older, to get that strain, especially if you do. So I see a lot of male runners in their 50s who do a lot of ultra events and, trail events, where they come with this sort of constant soreness around that sort of pubic bone, adductor bone, and they have quite poor hip mobility because of that sort of normal age-related changes. They don't have osteoarthritis, but it's just a bit stiff, and maybe they don't do enough mobility work or cross-training. they're not doing any swimming or other stuff. So they're just running, typical runners, they just do that all day, 5 days a week.
Is there much you can do to combat that, the effects of
Yeah,
reduced mobility in the hip?
Yeah, so what we get, there's some evidence that eccentric training can help you to lengthen better than stretching. So a simple body weight Bulgarian split squat is a big, I use it all. So I ask them to do them during the sort of day, just do about, 2-3 sets of body weight Bulgarian split squat rather than stretching it out. And also the thing with hip extension is it's closely related with the lumbar extension. So it's a coordinated movement there, one doesn't work on that. So if you lack good lumbopelvic control, you might not get that good hip extension. But having said that, you can improve what you have with some drills. So you can do some running drills trying to encourage that hip extension, and cues when they're running to push off more with the big toe to get that sort of, because we want to engage the glute max, get that sort of stride there. So we find that getting, and one of my favorite exercise to get that sort of pattern is to use glide discs. The discs where you can a really good exercise for that population or anyone you want to improve hip extension. Just go slide it in 2-3 direction, hip extension, hip abduction, all that. So it's a good, like, rather than just passive stretches, I'm a big fan of dynamic mobility. So you could use that sort of pattern to get that sort of so you could call it more like movement prep before a run. So you could add a little bit of plyometrics, low level, bit of hip extension drills, and then you're going to maximize your running efficiency as well. So definitely we want to encourage but maybe in the grand scheme of things, it might eventually go down, but at least keep it more efficient as much as you can. So getting that sort of mobility element. So initially when you're dealing with this, as I said, is one of the things I do is to avoid excessive change of direction. So I'll say not to run on uneven surfaces, not to do side to side, and really focusing on improving the range of motion, especially in hip extension and abduction. And if you do have some myofascial myogenic pain, they respond really well with hands-on treatment. So so you can do your hands-on soft tissue assisted stuff or instrument assisted stuff, and some people also do really well with dry needling, as long as you respect the tendon. So I'm not a big fan of poking the tendon, but because the tendons they have less blood flow and less oxygen than muscles, they don't like that overstimulation. But definitely soft tissue work will help. And there is some very low level evidence that using compression shots, like this sort of Under Armour X-shaped, that can give you some symptom relief. So if you have somebody who's got uncomfortable groin when they run, I'll ask them to wear that sort of the Under Armour. There are different companies who do that sort of cross link, and that anecdotally it's not going to fix it, but they're going to feel less pain, which is always a win-win situation, isn't it? So again, it's an adjunct.
So if you're treating somebody who's got rotational activity as part of their sport, if it's hockey or football or something, and they've come to you with an adductor strain, I mean, their game is going to be based on changing direction quite a lot, isn't it? So with a runner, with a lot of the way we can change the way they run slightly, and they can keep running. But I mean, I'm out of my depth here because I don't really look after sports people or hockey people unless I can help it. With them, are we more likely to say you've got to stop playing for a while? Or
I think the only few times where I'll stop them running, playing totally, when they have night pain and they're limping quite badly. So if they're limping quite badly and they're really hobbling the next day, then maybe a short course of 2 to 3 weeks might be necessary. It depends on if they come really severe. Most of the cases we don't have to stop because the complaints is very poor. So one of the things we can say is to reduce explosive speed. So I'll ask them not to, suppose they're a winger, I'll ask them to change position to come a bit more central rather than just bombing in. Doing that fast cutting in is where the problem. A bit of straight line is totally fine. So the fast cutting in and that explosive speed is where it struggles. So maybe they can change that, reduce the speed, and also, do that, and also use the compression shots for pain relief, and some dynamic mobility drills and some hands-on treatment as well. And then we'll definitely have to include some rehabilitation exercise. So the way I look at the rehab around the region is to keep it quite simple. This way I usually teach on the courses is look at those 3 key muscle groups around that region. So a very simplistic way of looking at it is you got a very powerful hip adductors is as a group. they are more powerful than even the mighty glute max. So it's quite a very powerful muscle, the adductor muscle as a group. Then you got your hip flexors, key for power generation, sprinting. And then to contract it, you also have the lower abdomen, the muscles which attach to the pubis. So these are the three main groups which should be in sync. So if you look at this sort of historically, just giving a bit of from the English Premier League, this is a sort of well-known fact, is before Arsene Wenger came in, when he joined Arsenal, there was a lot of high incidence of this sort of sports hernia, lower abdominal tears and other things. So he introduced a lot of lower abdominal strengthening, the traditional core stability, but it's focusing on the lower abdomen, because usually footballers tend to have very strong adductors because they're kicking all the time. But you need to counteract that with good hip flexors and also lower abdomen. So if you have that sort of imbalance, then you're going to lead to more muscle injuries and strains. So we found once he introduced that philosophy, other clubs picked up, and it's quite it had a massive drop in those sort of pathologies, because he was addressing the balance between, because he came, he was quite novel at this time. He was coming with a lot of scientific facts there, which is breaking that traditional football model of just going hard all the time, so he was trying to look at recovery, the muscle balance. So that is sort of well accepted now, is to really look at the balance between those sort of three key muscles. So what you might do is you might start with some early adductor exercise, some of those exercises which sort of you can sort of gym ball squeeze. So a simple a key sort of, if you just want to get the whole concept, an easy way of getting that is something called the 𝐿 protocol. 𝐿. He was the first guy who published in 1990. So if you just Google the 𝐿 protocol for adductors, you'll get pretty much all the exercises for adductors. That's what I use. That's one of the first trial. Those exercises are still useful. That's open access.
I think we've got it. I think Dora mentioned it last week. Yeah. And she gave me a link to it, and we've got like about 26-page PDF, which is in the show notes for last week.
Yeah. So that sort of is your starting point to build that up. So because that's well proven there. And then you also want to start some early lower abdominal exercise. So some of the dead bug exercise, something with the gym ball, some of the simple plank options. So you really want to get those activation around that region, and also making sure that they're able to engage those sort of muscles around the pubic bone. And then once you progress them, then you can definitely add, then the glide discs, then you can add some therabands. Then you can look at some slings in the gym, build up that sort of strength there. And also not to forget about hip flexor. So initially, hip flexor is like, some people think you need to stretch all the time, but initially you don't want to do strengthening because it just irritates the hip. But at a later stage, you can start with, some low-level hip flexor strengthening exercises. You could start with some bands, cables, and then get that sort of, when you look at that explosive power, it comes mainly from that hip flexors and adductors. When you sprint, when you change direction, those two muscle groups are really important. And then at, like with any lower limb rehabilitation, at one stage you'll have to include some plyometrics, so you'll have to do some plyometric drills. Then you have to look into sports specific sort of change of direction drills. So for me, for example,
sorry to butt in, that tends to be the end rehab, tends to be the bit which an athlete doesn't do, and then they're back in clinic again with the same injury.
So one thing, an easy tip I sort of use with this runners is, say, most runners, when I get them back running, I use a graded return to running, like some form of couch to 5K, something like that. Now, when I'm treating an adductor or a groin injury, what I will insist there is, just like we use for runners, I use a free program, easily accessible program called FIFA 11 Plus. So FIFA 11 Plus is a free program which has been shown to reduce the incidence of groin injuries and even knee injuries. So I ask them to do that on their own with the football or in the pitch for at least 2 weeks before they start with their mates. So that's a very important point to remember, is you must have sports specific training, and there's nothing more evidence-based than FIFA 11 Plus. So if you just Google FIFA 11 Plus, you'll get a PDF sheet with all the...
This is with the shuttle runs and kind of figure eights and stuff. Great.
So it's something which is very specific for outdoor change of direction sports. Even if you are a rugby player or a hockey player, you're going to still get benefit from 11 Plus, because you're training a movement pattern there, and also that sort of change of direction, which is very hard to do that in a gym. Like you can, you're not going to get that by doing deadlifts and squats and things like that, or hip flexes. So you need to reproduce. So my general rule is, do the FIFA 11 plus for 2-3 weeks. Once you sort of get confident with that, then go and do training. Don't do the match. Just go and train with your mates at a low level. Just have because a lot of times it's a psychology class, so they need to get the confidence. So next step is to go and play, do a bit of training, but don't go to the match. And then once you've done for 1 or 2 weeks, then the final step would be suppose, let's give football. That's an easy example to do. So a football match, as we know, is 90 minutes. So when you go back, you've done the FIFA 11 plus for a couple of weeks. You've done training with your mates, not a match. And then when you go to the match, don't play 90 minutes, please. Just stick with 40 minutes, 45 minutes, then add 10 or 20 minutes each week. You build up. So it's just like graded load exposure, but specific. We do it for all injuries, isn't it?
Would you put them in for the first 45 minutes or let them play the second half?
Yeah, I generally go for the second half because the other people are tired.
Then they can't continue. Yeah, exactly. Yeah.
Others are tired, less likely to fail. So you could start with 45 minutes, then increase by 20%. So it's being sensible in that sort of progression. So what we don't want is you've done the rehab and say, oh, you can play football tomorrow. That is disaster. You're not ready for that sports big. So I think what we see is that end stage transition to sports specific rehab is really important. You don't want to really make them, because however good therapist you are, you can't reproduce that sports specific demands in a gym or in a cubicle or any fancy physio place. You can't reproduce it. Those specific stuff has to be done in that sort of environment, which is very unique to that sport as well. So we can definitely, even give an example, like I've used even the FIFA 11 plus in a 65-year-old doubles tennis player who plays recreationally. So it doesn't have to be just football, because you're doing it, that movement specific drills there. And once you've done that, then you can definitely. And another thing, a key tip would be here is, we know the biggest injury risk is previous injury. So a common mistake we see in patients is they've done the rehab, everything is going hunky-dory, and they're going back playing football or tennis, and everything is nice. They stop doing the strength exercise straight away. And we know that, when we have a drop in your adductors, things like that, that's a risk factor for getting another injury. So a key point we want to emphasize in this patient is we definitely want you to continue the strength, not every day, but at least twice a week for the next 3 months, because you're slightly high risk and vulnerable of getting the same injury again. And we don't want that to happen. You've spent a lot of time on the rehab. Why don't we just continue some key exercise for the next 3 months, just twice a week, some of the adductor, some of the modified Copenhagen, some hip flexor drills, some lower abdomen, just simple 4-5 exercise as a maintenance for the next 3 months. And that will prevent it from happening again. And that's a common mistake I see from patients. They stop everything and just go back to the sports, So do you see that with the runners? I see that runners all the time,
I think it's where therapists need to have a good relationship with coaches and get used to being employed, not just to run down the pitch with a sponge, but also to get involved in the rehab. And like you say, when somebody is playing, the other one could be doing the FIFA 11 plus on the side or something, and you're watching them and checking, get a few of them to do it. Even because a lot of these kind of protocols for rehab, we don't know whether it will prevent injury, but it's a pretty good reason just to do it in case. We can't promise it's going to prevent it, but it's going to be a good form of training for all of them, isn't it?
Yeah. So, and the thing is, this is something, and see, for me, from a sports point of view, I know a bit of running, I know a little bit of cricket. It's impossible for us to know all sports, as a therapist. So, but again, you could use a generic program like FIFA 11 plus for any rotational. And if you Google, there's Australians and the Kiwis have done a lot of work on netball. So there is some netball specific warm up. So if you Google injury prevention warm up programs, there's a lot of different programs for different sports, and then you sort of collate them and you can give it to the patients. And these are all a lot of work done by clever, academic researchers. But one of my biggest passion is to translate research into the clinical world, because there's no point somebody doing a PhD and somebody sitting there. We need that work to help people, isn't it? So that's why we need to help in that sort of program and how to make it interesting. Because lack of pain doesn't mean like you're totally cured. We know that these sort of injuries have a high recurrence, So I see that
Yeah.
they pull the adductors, they don't rehab enough, and then in 3 months they come with a hamstring injuries and things like that, because the rehab is sort of they feel I'm fine, I don't have pain, I can run 30 minutes, I don't need to continue with that sort of long standing things. And I think that is another one of the important elements to gain compliance, I find, is to give them some markers, strength markers. For example, like
Mhm.
simple things you could use is a single leg press 1.25 times your body weight, so you can do
Mhm.
that. Or simple things like I use handle dynamometer, so I look at the ratio between the abductor and adductors. So the normal
Mhm.
ratio is 1:1. So with whatever tools you have,
So what
but
was that ratio again?
for a normal population like non-run and non-football, it's between 1:1. The adductors and the abductors should be the same strength on
Okay.
that. But if you're doing like football, hockey, and rotational sports, it's generally better to be 20 to 30% better. So it'll be 1.3:1. So if you're playing
Okay. In
football,
favor of the adductors.
yes, yes. But
Yeah.
for a runner, it's not at all necessary. If you're a runner, you don't need that sort of higher A deductors, because A deductors gives you that sort of change of direction benefits,
Mm.
which a runner doesn't need that. So for a runner, I generally go for 1:1. But if it's more the rotational population, I'll go from 1.2 to 1.3. So things are getting more cheaper. Like 5 years ago, it used to cost like 1,500. Now we got some good companies where you can get the good handle dynamometer as a clinic for 300 pounds, 350 pounds. So as
Mm.
a clinic, I think it's a good investment. And you can give them some good objective markers and say like, this is the strength markers, this is what you need to achieve in the gym. And people like the challenge, isn't it? Rather than just going to the gym randomly and just doing a circuit, they'll say, I'm working on something here.
Yeah, it gives them a goal. I
Mm,
wanted to check with you.
mm,
It's already 8:54. You've given us so much already. It's incredible. This is definitely one to listen back to. We mentioned last week, or Dora mentioned last week, a lot of the time it's the adductor longus because of its position and the mechanics of it and the load it has to tolerate. When
mm.
it comes to rehab, is there any twists you do to exercise in order to engage the adductor longus more than the others, or will
Yeah,
it
I
always
tend
be
to. So
involved?
yeah, so this the thing is, I'm the statistically, the adductor longus is the most common. I think from what I remember, it's 70% of the injuries happen in the adductor longus, is by far the most common, because it's also involved in flexion. So
Mm.
it's sort of, you can attack it in different ways. So I tend to work in different groups. So for example, you can do like squeeze in a bridge position where you involving the magnets. You can do
Mhm.
you can change the recruitment of the muscle will depend on the position of the hip. If you bring it more towards the flexion, more towards extension. But I would not be brave enough to say that I'm isolating one group, just one
Mhm.
muscle, because I think I think it's quite hard to do that, because they work together in synchrony. And you have to remember, like for example, like if you're doing a squeeze in a long lever, you're going to involve your lower abdomen more than when you do in a crook line. So even the lower abdomen will get changed based on the position, because the to be efficient, you need to involve the adductor. So one of my favorite exercise would be is in a crook line position, have a small, like a pilates ball, squeeze, and then come in a half crunch. So squeeze
Okay.
first, engage the adductors, and then get the lower abdomen involved, so that you're really going into the natural pattern of involving it, because that's how it works. So they
Mhm.
go together, they really stabilize the pubis.
Yeah.
And again, when you're doing the glide discs, so it's just not mobility. When they bring the glide disc back, I'll ask them to push the ball of the big toe and to engage and to drag it back. It's not slide, it's
Yeah.
dragging. So
Yeah.
this are subtle cues you can give when you give the rehab to get that engagement, rather than just doing like a fun sort of mobility drill. So push on the ball of the big toe, just drag it in as if you're scraping the surface, and you're going to get better engagement rather than just
Brilliant.
passively on that. So those are the things. So I would say, if you're doing adductors, please don't do that in isolation. Always engage the lower abdomen, which is a better way of doing it, because that's a natural way of stabilizing the pelvis. What we don't want is a ridiculously strong adductors without nothing to oppose it. So
Yes.
we need a strong. It's like, for example, give a perfect example would be knee. For example, ACL. We need the balance between the hamstring and the quads.
Mhm.
So if the quads is ridiculously strong but the hamstring is weak, we know that is a risk factor, especially in females. So the
Mhm.
same thing is, we want good symmetry between that sort of those three major groups. So and the body works together rather than just like in isolation. So isolating one muscle might be something you do initially, but at a later stage you're looking at the synchrony between these three groups.
Brilliant. And other question I wanted to ask you was, during rehab, where do you sit in terms of what pain should be expected, or should it be totally pain-free, or how do you
So I think is, if you expect to be totally pain-free, it will take 3 years before you decide, before you decide patient. So I think, see, that's a subtle, there is some clear guidelines we need to work with. Is the feeling of discomfort around the groin is not a natural thing. So first we need to sort of desensitize and make it normal that bit of tightness is normal, especially if you're doing a lot of sports, especially you're doing a lot of, you feel that. So generally, just same like with any tendon, I sort of use that sort of classical between 0 to 4, 0 to 3 or 4, like mild to moderate. But the most important thing is for me is the next day. So so even if it's 5 out of 10, but next day morning you're not limping, I'm not too worried, because so for me the main thing is, how do you feel the next day? Do you feel any? So what typically is, if they overdone it, there are a few things they will say. They'll say, when I get up, I'm hobbling a little bit, I'm limping a bit, and then it's very sore around my pubic bone. Those sort of things, I don't like that, because that means you've just done too much on that, So I give more importance to the 24-hour response than actually to the level of pain. I said to them, nothing too sharp. So again, quality of pain, nothing too sharp, nothing pinchy and stabby, because that sort of tells me that possibly you're irritating the hip joint, but a bit of an ache, totally fine. If you ask most people who do a lot of these rotational sports, they're going to feel that tight, that's a common thing, just like you feel on upstairs. So the problem is when it becomes sharp, and then also when it starts affecting the performance, they are finding it difficult with sprinting. And also, so if you look at most of the professional clubs, they'll monitor the adductor strength. I don't know whether they do it every week or every day. So we know those drop in strength is an indicator of an injury happening, so in few days or few weeks. So if we can monitor the strength regularly in professional sports, and if you have a drop, that is the best indicator. It's like sometimes when you get a cold in 2 days, you get something, a bit of a niffly nose a few days before, and you're going to get a cold. The same thing. When you have a drop in strength, something is coming. So
that's interesting. So that's something you could do when people come to you for maintenance massages and just to check in. And that's one of the tests you could just do.
So you could check that. You could say like you're dropping strength, so you need to get back on your thing. So again, you can monitor those sort of thing. But a bit of pain is totally fine. Nothing sharp, pinchy, and you're not hobbling the next day. And then those sort of things are really more important than sort of thing. Another thing is what an element of rehab is, you mentioned about the end of stage. One thing which sort of I always insist before you go in rotational sport is, you must be able to do 5K, before you go to any sport. Because for me, if you're not good in straight line, if you can't run 30-35 minutes, you'll always be a liability in any sort of sports. For me, that is a baseline fitness. You need to get back. A lot of these people, it's the opposite. Like runners hate the gym. A lot of people who play rotational sports, they hate running, because they don't want to run, because they said, it's boring. Running is so boring, I can't do that. But I say to them, you need to get that cardiovascular fitness. There's no better exercise than conditioning than running. You whole lower limb, your cardiovascular fitness. So I insist they should do the 5K sort of if you're really good, like sub 25 or something, like a good run there, build that sort of level. And that's not commonly encouraged, is to get back running straight line. So get the straight line running first before you do fancy side to side stuff. If you're not good in a straight line, you're never going to be good on side to side. So running is still a fundamental requirement. So it's like I watch my son. He's 10. They do football and they make them do a lot of running around. And my son hates that and say, I just want to play football. But I explain to him, like, you have to get the running right. The engine has to be strong. Your leg muscles, your calf complex, and sometimes that in that group I find very hard to encourage straight line running. Do you find that?
Isn't it? Well, I'm someone who doesn't like chasing a ball, but I'll gladly run for ages. So and some people love chasing a ball and they don't just like running into nothing. So
running is,
ironically,
I would say running is a fundamental skill in all lower limb rehab, whether you're a runner or not, in my opinion, you should be able to do at least a good 5K in decent time before you do. People will say, when can I play tennis? I'll say, can you do a 5K? If not, let's talk about it later. Let's do the 5K first before you do the tennis, because getting that sort of cardiovascular fitness is so crucial. And I'm an opinion, most people can be trained to do a 5K, sort of, even if you're 60, 70, it's a doable number for most people. Not everybody wants to do a marathon, but most people can be trained for a 5K at least, isn't it? Before you do some rotation. And I think that's fine. Is there's two things. Is the re-injury rate happens of two things. One is lack of the sport specific transition, like the FIFA 11 plus, and the second is the lack of conditioning. People use the word strength and conditioning. They do a lot of strength work, but there's no conditioning. A lot of the drills, a lot of the running stuff, a lot of the speed drills, that is so important, because just doing traditional strength work in the gym without the conditioning, you're not going to get that sort of sport specific element as well.
Brilliant. Right. Well, there's so much there. I wish I could just sit back and listen to you another half an hour, but it is 9:03, and I'm sure you've got things to do. But I really want you to give our listeners an indication as to what courses you've got coming up, and give you some time for that.
Maybe I'll just show my book. Maybe I'll just show.
Oh yeah, just to give people an idea, because there's so much there which would help people.
So this is sort of I'm one of the chief editors, so I wrote a couple of chapters on this. So this is sort of available on Amazon, the hip and knee pain disorders. So is available. So it gives you, especially if you want to look at the rehab for all the key muscle group, proximal hamstring, adductors, the GTPS, the soft tissue, and also there's a good chapter on, not by good manual therapists, on the soft tissue techniques, manual techniques for the hip. Belt, Thomas Mitchell is a Mulligan teacher. He's done a fantastic chapter on that sort of thing. So there's a lot of element on the hands-on treatment. One of the things which we want is this sort of debate in physio world about the hands-on, half soft. So we wanted something which is like a practical, what I do in the clinic. I only wrote what I do because I do a lot of hands-on. I do a lot of manual techniques on my hips, especially if they had like surgery and other things. So we want a real manifestation of what I do. Obviously, the rehab is important, but you need to focus. So we address the soft tissue element, we address the manual therapy, and also a big emphasis on the rehab and that phase. So I think it's sort of a good. Excellent. And the other thing is, you don't have to read all in one go. So suppose, let's say you got a patient with proximal hamstring tendon, you can just look that, just read that. Or a patient with hip dysplasia, you can just read that, and then
make sure a link to that goes into the show notes.
So that sort of is something where you can, and then on Twitter you can see I'm doing a course. I think it's sold. I think next week I'm doing in Withington. So best place is if you follow me on Instagram, and I can give you the links, and Twitter, LinkedIn, so you can see all my courses. So I do coins regularly. So if you missed the one, if you missed the London one, you can come and join me in Dubai. Or in Belgium. So or Iceland.
So on Twitter, you're Function to Fitness with one S, because it's not long enough for two S's.
And the Instagram, double S.
It's going to be the whole lot.
Double S. So you can do that, and then you can. So I think the hip and groin doesn't have to be hard, and I think it's just like a key point before I forget is, if you have somebody with a chronic groin pain, it's just, rather than worrying about all this fancy stuff, first making sure that it's not MSK, it's a women. I went through the question, making sure that we are not missing that sort of red flags, non-MSK, non-MS. There's a lot of emphasis on MSK red flags, but the non-MSK red flags are equally important, the cancer, the other sort of gynecological conditions and things like that. And having women's, for me, I think is, in lower limb, I think a very important person I work with is women's health physio, because for them, they are so important for me in that sort of getting the pelvic floor element, especially in 80 to 90% of hip and groin patients I see are females. I see a lot of GTPS, a lot of things. Whereas if you work in professional sports, most of hip and groin is men. It's quite opposite in private practice. The majority of patients I see is actually women. Most of hip pathology is women. So, and when you're dealing with women with hip and groin pain, getting that pelvic floor really addressed and looked at, without that, you're not going to get the full outcome, really, especially if they're postpartal. A classical group would be, let me give you a couple of simple cases I would share is, a lot of women start running postpartal because it's a great exercise, but then the pelvic floor element has not been addressed and they get hip pain. So those patients should be managed by two people. I manage the hip side, and somebody else manages the women's health address that. So working close, working close, because for a lot of women, running is the easiest option, especially postpartum, isn't it? They they don't have time to, they just get, but they don't have that, they will not address the whole thing together. So and then look at simple conditions like hip OA. So don't assume just because you're 38 or 41 you don't have arthritis. Simple questions like putting shoes and socks in the morning, family history of early arthritis, limping, and and again, if you have mild arthritis, you can still keep that going for a long time. Doesn't mean that you need a replacement next week. So again, a lot of education that arthritis doesn't mean natural. But you do find an opposite happen is where people have been told that you are too young for a replacement. So the youngest patient I've sent for a total hip replacement is 23-year-old female. Actually, she was a physio student. She had quite severe dysplasia, which was missed when she was young, and her quality of life was really poor. She could hardly walk for more than 10 minutes, limping, and she's been told by so many people. Like I think she was from Norwich or somewhere. Like like they didn't have big big centers, and she was been told by the local physios and the local orthopedic department that she's too young to have a replacement. And she attended one of my course, and she came to me after the course, and she was in tears because she thought she has to live like this for the next 20 years.
Yeah,
and
so
then
sad.
so I said to her is, this is your life, quality of life. I looked at the X-ray, was quite severe, but also the symptoms was really severe. So I said to her, ask your GP to refer you to UCL. So, because I know a few of the surgeons at that time. So she was referred, and within 2 months, she had a total hip replacement. And I saw her a few months back, and she was running. In fact, she came to me for a gait analysis for running after a thing, and she was doing horse riding and all that. So for that person, the right information, sometimes telling them that you're not too young for a replacement, it was a game changer. People have this misconception on that. So you could really make a massive difference there.
We had Holly Soper-Doyle on,
yeah,
hip dysplasia physio, and she painted a very sad picture as well through her own case and the case of many women who is undiagnosed for ages. You keep seeing the same thing happen again and the same.
Yeah, the same
but
story.
Anyway,
you're too young, you're too old. But the thing is, again, the thing is in London, which is a bit unfair on the whole country, is we spoil for all the top centers. So you have UCL, Stanmore, you got guys, so whereas you got pockets in the country where there's a sort of dry line, there's hardly any sort of young hips there. So there's a bit of a mismatch between the country. So sometimes people get lost in these pockets where they sort of suffer for years or even decades. And that's why the forums like Twitter. So I get every week, I'll get 2-3 emails from physio colleagues and say, can you please check this X-ray or the report? It's been told you have a normal. Another big problem is they've been told there's nothing wrong, usually in dysplasia. And then you tell there's obvious dysplasia and then say, I guide them accordingly, So sometimes it's having the network to have that second opinion. And a lot can be done nowadays with online. So building up. So I think I rely heavily on my support system with, sports doctors, pelvic health physios, orthopedic hip surgeons. So if the hip and groin, it's impossible on your own, really. That's something I learned quite early, that you must have your support system for you to get. I sometimes I call up and say, I'm stuck here. Can you please check? And there's nothing wrong in that. I send at least 2 patients a month where I feel I really don't know what's happening. I don't have any problem with that. So I send to a few people I trust and say, I think I'm missing something here. Can I have an opinion? And vice versa. Sometimes I get some top hip surgeons book with me and say, he's going to have surgery, but I want to make sure that I'm not missing anything. So they value my opinion, because we are all here to help a patient regardless of whichever position we are, isn't it? Because I bring some strength, whereas a surgeon brings some strength. So whereas a soft tissue therapist, they will know more on those elements. So it's working together as a team where we can make a big difference.
Definitely a fantastic message to end on. Right. Well, thank you so much for your time, Benoy.
Yeah.
Talking of pelvic health and everything to do with it, we have got Jenny Burrell on next week. She's going to be focusing on diastasis, rate tie, but I'm sure she'll be dipping into some of the things you've talked about as well, with regards to tendons and menopause and the other things she specialises in. And that will mark the end of has been a fantastic month. Thank you everyone who joined us in the live lounge. Penny here has just said, super great month overall, Matt. All speakers have been super informative. Looking forward to next week too. Thank you again.
Thanks, Matt, for having me. And
absolute pleasure. No, thank you for saying yes. Gary Benson said it's been really interesting, reinforcing some content, really useful rules of thumb and observations. Definitely going to re-listen. Thanks, Benoy, for sharing your knowledge and expertise with us. Definitely. It's been a packed hour. Thank you, Benoy. If you can just hang around for a second, I'm going to shut down the live lounge and then I'll say thank you to you very quickly in a second. So thanks, people, for joining us. If you listen to the podcast, then please do us a favor and just quickly give a rating and a review. If you're on an iPhone, then it takes a second. You literally just got to put 5 stars and say thanks very much, it was great. It just helps the word of our speakers get out there more. We're talking about this misinformation and misdiagnosis and lack of diagnosis. One great way we should be getting this message out there is through social media and things like this. So please don't just listen to this and keep it yourself. Share it with some colleagues. Leave a rating so it appears higher in Google, so we can get the great word of people like Benoy Mathew out there more than it currently is. If you do want to join us, then, like I say, it will be Tuesday next week on May the 30th with Jenny Burrell. Just come along to the Sports Therapy Association YouTube channel, and that'll be it. Until then, thanks very much, and take care of each other.